and diagnosis. So in this introduction, I'm going to introduce you various important terminology from our subject, and then we are going to see the various diagnostic tools which are available for orthopedics to arrive at your final diagnosis. So let's get started. So today we'll start our class with the very first definition of orthopedics. So this is the term which was coined by Nicholas Andre. So Nicholas Andre is the person who has coined this term orthopedics. And what does the term orthopedics mean? Orthos means straightening or correcting, and pedics means children. So he has described orthopedics as an art of correction or prevention of deformities in children, right? And if you can see the image on the screen, this is accepted as the emblem of orthopedic surgery. What does that define? That is the definition again, where you see a crooked tree, which signifies the crooked limb or the deformed limb, and then this is supported by a stick and the rope. That means it is splinted. So it again explains that correction of the deformity, right? So that is the meaning of orthopedics, right? And then let's see the historical importance and various orthopedic contributions from various surgeons. So that starts off directly from Hippocrates, who was considered as the father of medicine. So he has given his contribution by introducing the terms the traction and the counter traction. So these are the terms which are used for reducing the fractures, right? So he has introduced these terms and has given the details of how to reduce a fracture. And if you remember, he has also contributed one of the technique for reduction of your shoulder dislocation. So there is Hippocrates' method of shoulder dislocation, but it is not used now. And then he has also contributed for correction of clubfoot deformity, right? So these are the contribution made by your Hippocrates. So there is a correction of clubfoot deformity which was described by him. And then next we'll see about two important scientists, that is Hugh Owen Thomas and Robert Jones. Right? So these two are related. Jones is nephew of Thomas, right? So in studying about this Thomas, he's very important as he has contributed very much to orthopedics, and these two are considered as fathers of orthopedic surgery. And coming to Thomas, his contributions which you have to remember are, first there is Thomas wrench. So this has been used to manipulate the fractures. And then there is Thomas collar. So Thomas collar is used for cervical spinal injuries. And then there is Thomas splint. And finally, there is an important test which is called the Thomas test. So coming to Thomas splint and Thomas test, they are important for you to understand regarding the questions, right? So this is what is called the Thomas splint. Fine, this is your Thomas splint. So what is the splint? So if you see the parts of the splint, you can see an oval structure which is called the ring, and there are two bars. So this is your outer bar. How did I identify it as outer bar? Because this has a specific, if you see the nook, that is to accommodate your greater trochanter, right? And then this is your inner bar, right? And this ring makes an angle of 120 degrees. And there are two bars, as I've already explained, they're connected below, and this acts as a splint. And this was introduced during World War II for patients who were diagnosed with skeletal tuberculosis. But now, presently, it is using as a splint for transferring patients with femur shaft or distal femur fractures, and it can also be used as a fixed traction device, right? So this is about your Thomas splint. This could be a potential question in your exam, right? And then coming to Thomas test. So coming to the Thomas test, this is the test which is used to identify the fixed flexion deformity in hip. Right? So in hip conditions such as your avascular necrosis, in case of your tuberculosis, there will be certain deformities which are present in the hip. So one such deformity is your fixed flexion deformity, where patient will be unable to extend his hip. So to quantify this fixed flexion deformity, we use this test, what is called as Thomas test. So by this test, you can confirm the flexion deformity and you can quantify the deformity by using your goniometer. So these two are potential exam questions. Hence, you have to remember this was invented and contributed by Hugh Owen Thomas, right? And coming to Robert Jones. So Dr. Robert Jones has also contributed so much, and two important contributions which you have to remember is the Jones fracture, which is seen in the fifth metatarsal base, right? So this is the fifth metatarsal base fracture, which is called the Jones fracture, and then you have your Jones bandage, Robert Jones bandage for your for knee effusions. So whenever you have knee effusions, you aspirate knee effusions and then put this Robert Jones bandage. It is a layers of soft bandage by roller bandage. So this is called the Jones bandaging technique, right? So these are the important contributions by our eminent orthopedic surgeons. And then you have your father of arthroplasty. So what does arthroplasty mean? Arthros means joint, plasty is replacement. So he is John Chanley. So this person is considered as father of arthroplasty because he has contributed so much for the replacements, and their Chanley's principles which have been followed for these replacement surgeries. And then you have to remember the father of arthroscopy. So arthroscopy is one more specialized branch of orthopedics where it is emerging because after the introduction of scopes into the joints, there is a lot of new advancements in this subject, and this is separately dealt as sports medicine, right? So the father of arthroscopy is none other than Watanabe. right? So he is considered as father of arthroscopy. So these are some of the eminent personalities which you have to remember, okay? And then coming to the terminology. So I've already told you, after reading little interesting historical importance, we're going to understand the basic terminology in orthopedics, right? So before understanding this basic terminology, let me introduce you what is the anatomical position of the human body. So as you all know, you have learned it in your very first year of anatomy. What is the anatomical position? So erect posture in spine and two limbs, or body balancing on the two limbs with the feet pointing forwards and head pointing forward. So this is your anatomical position. And the important point here is in the arms. So your forearms are in supination position with the palms facing forwards. So this is exactly what I told you is the anatomical position. And when such body is placed in space, it can be divided into three planes. So the first plane here is the sagittal plane, which I'm explaining. So what is a sagittal plane? So sagittal plane is that plane where you can divide the body exactly into half, right? Exactly into half. And these halves are nothing but your medial and the lateral halves. Your medial, they become your medial half and the lateral half, right? Or your right and left half. So exactly you divide the body. So you can see the medial side and the lateral side of the body. So that is your sagittal section. And then coming to your second plane, that is your coronal plane. So what is your coronal plane? Or this is also called as frontal plane. So this is the plane where you can divide the same body into two halves again. So these halves are nothing but your anterior and your posterior. So this is the division that has happened. And now you divide the body into two halves, what is called as your anterior and the posterior, right? Anterior and then posterior. Okay, and then the third one is your transverse plane. The third one is your transverse plane. So in this transverse plane, what will happen? In this transverse plane, the body is divided into two halves again, but this half is into upper half and the lower half, right? So you divide the body into upper and the lower half. So that is your transverse plane. Upper and the lower half. So these are the three planes of the body, the basic fundamental of understanding the position of the body, and these are the views from which you can see the body. So when I say sagittal plane, so in this particular diagram, see if this is a sagittal plane, so this is a sagittal plane. It is dividing the body into two halves, exactly like this. You can divide into right and the left halves, right? So you see the medial structures and the lateral structures. And then coming to the coronal plane. Coronal plane is C-shaped, right? So this is something like this. It will divide the body into C. So coming like this. So here, when you divide the body, you can see two surfaces. That is the anterior surface and the posterior surface. And this is the transverse plane where you can divide the body into two halves. So you cut the body like this, exactly like this. This is the upper half and the lower half, right? So this is about the planes. So this is about the planes. And now coming to the various movements of the body. So coming to the movements, they occur in the particular planes. So that is why we have dealt with the planes first and then coming to the movements of the body. So all the joints, they move, right? So that is the dynamics of orthopedics, right? We are able to move from one place to another place. This movement happens, and this is because of your presence of the bones, joints, ligaments, tendons, all working together. There is a movement that is occurring in the body. So there are various names given to the movements. So first movement, and this movement occurs in the sagittal plane, right? So this movement is happening in the sagittal plane. The movement name is your flexion and extension. In case of your foot, that is in case of your ankle, foot, and your wrist, these are similarly termed as your dorsiflexion and plantar flexion, or dorsiflexion and palmar flexion, right? So here coming to the flexion and extension. If you take the elbow joint, this is the flexion where you close, and extension is extending of your arm. So it is becoming straight. So this movement, whatever the flexion and extension, it is occurring in your sagittal plane, right? Sagittal plane, right? And then coming to your dorsiflexion and the plantar flexion, these are the movements which are occurring in the ankle. Ankle dorsiflexion and ankle plantar flexion. Dorsiflexion is when the foot is touching the shin, right? It is going up is dorsi, and when it is touching the floor is plantar flexion. Similarly, like your wrist. So this is your dorsiflexion and this is your palmar flexion. So upward is dorsal, downward is your palmar flexion. And coming to abduction and adduction, these are the movements which are occurring in your coronal plane. So these are nothing but your sidewise movement, right? What is abduction? Abduction means taking away. Abducting is lifting up, right? So taking away. Abduction and then adding to your body is adduction. Adduction is adding, coming closer to the body. Abduct is going away. That is adduction and abduction. So these are the movements which are occurring in your coronal plane, right? So coronal plane is plane where the body is split into your anterior and posterior halves, right? And next, there is important movement in the forearm. This occurs only in the forearm. That is your supination and the pronation. So this is the supination where your palm is facing upwards, and this is pronation. Similar supination and pronation can also be seen in the foot, but this is the amalgam of various dorsiflexion and adduction movements, right? So remember, supination is forearm supination where you see the palm is facing upwards, and pronation is palm is facing downwards, right? And next, your external rotation and internal rotation. So this occurs along the longitudinal axis. So this occurs along your longitudinal axis. So this occurs in shoulder joints and in your hip joints. So larger joints where you can see more freedom of the movements, right? So ball and socket joints. So this is the internal rotation and this is the external rotation, right? And this internal rotation and external rotation are mainly seen in your ball and socket joints, right? In your ball and socket joints like your shoulder and your hip joints mainly. So this external rotation is also called as lateral rotation, and internal rotation is also called as your medial rotation. So these are the various movements which are occurring in the body, right? And then we'll see one more terminology which is very important, and these are a little bit of importance which occur during pathology of a particular joint. So there are two important terminologies. One is varus and another one is valgus. So when I say varus, what does that mean? So if you put this as your midline, right? And this is your, what is this? This is your varus. Varus. So varus is what? Where your distal part. So for example, if I'm taking this is my distal part of the limb, right? Distal part of the limb. Now this is coming towards the midline. When this is coming towards the midline, then this is called cubitus varus. So elbow is nothing but your cubitus. So elbow is cubitus. So when the distal part is coming towards the midline, elbow is cubitus varus. When this distal part is going away from the midline, so this is cubitus valgus. So based upon the distal part, you can tell whether it is varus or valgus, right? So if the distal part is coming inside, so it is varus. So it is like this, right? It is varus. If it is going like this away from the midline, then it is valgus. Similarly, if you take this as your midpoint, so this is your valgus, right? So varus and valgus. And now when I say cubitus varus, that means elbow, right? And when I say genu varus, that means knee. Knee varus and knee valgus is genu. Manus is wrist. Manus varus and manus valgus is his wrist. Next, hallux. Hallux is your great toe. Great toe. Hallux varus, hallux valgus. So similarly, everything in terms of your distal part, you can talk. So distal part, when it moves inside, it is varus. So distal part is moving away is valgus. So in this knee joint varus, so this is the, if you take this distal part, you can consider this as your malleoli and this as your intermalleolar distance. So here the distance is decreased, here the distance is increased, right? In valgus, the distance is increased, in varus, the distance is decreased. So these are the small terminologies which you have to remember for better understanding of the topics, right? So now here by this we complete the basic terminology which we need to understand. And now let's go into the detail of diagnosis. So let's see how to diagnose a case in orthopedics. So always the diagnosis, you have to start with the history. So you always take a note of a very good history. So history is very much important and you take it very brief, and then you will follow it by your clinical examination. So there are various tools in clinical examination which are dealt in detail in specific chapters. So how to examine each joint and what are the findings you have to take them, consider in them, and how to proceed towards the investigations. And after your clinical examination, then you go for your blood investigations, right? So your blood investigations play a very, very important role even in case of orthopedics, where in their infections. So one such topic is infections, where you see the WBC count, the ESR, the CRP, the blood cultures. So these are various blood investigations which are required. And in your crystal joint disorders, where your uric acid levels are involved, and so forth. So the blood investigations always form a part and parcel for your diagnosis. And finally, the basic diagnostic tool which we have for orthopedics is imaging. So in this imaging, one such tool is nothing but your X-ray. So this X-ray or radiographs are considered as the basic tool for orthopedic diagnosis. And this X-ray is followed by other parts of imaging. So other modalities like your CT scan, your MRIs, your bone scans, your PET scans, your DEXA scans, and then followed by your synovial fluid analysis. So in such joint disorders, there is a special analysis where you can do is a joint fluid analysis. And ultimately, it is the tissue diagnosis where we confirm the condition by your bone biopsy, right? So this is the pro forma where usually we follow for coming or arriving at a diagnosis. Sometimes the diagnosis might stop with imaging. Sometimes it may continue up to your biopsy. So that depends upon the specific conditions. So let's get into details of what are the diagnostic tools which are available and how to use them in our subject, right? So first we'll start off with the diagnostic imaging. So when I say diagnostic imaging, that means we always start with our very important and the basic X-ray. So what is an X-ray? So sophisticatedly, X-ray is also called as radiograph, but we'll put it simple. We call it as X-ray. So what is an X-ray? X-ray is discovered by Roentgen, you all know. And how is this X-ray formed? Usually we'll have this X-ray machine, right? And here, what will they do? They fire these electrons, right? Firing of electrons at a high speed in a rotating anode. So there is an X-ray machine, and in that machine, you fire the electrons at a very high speed on a rotating anode. And these electrons now go and hit your body. So if whenever there is an image, like for example, your X-ray machine, this is your X-ray machine, right? So this is your X-ray machine. And now there is, you want to take the X-ray of, for example, say spine, right? So you want to take the X-ray of the spine and you place the patient here, right, in the center. And now because some obstruction is there, all these, whatever the electrons are fired at a higher speed, the speed is attenuated. So that means they are reduced or obstructed. And now because of this obstruction, they cast a shadow. So whenever they cast a shadow, this is collected on this cassette. So there is a specialized cassette which is present there. So now the shadow, whatever is there of that particular spine is collected on this cassette. And now this is formulated based on the software. And that is how your X-rays are produced. Right? So here what is important for us is, what is this attenuation? So this is nothing but there is the impenetrable tissue. So the denser, the impenetrable tissues which are obstructing this electrons, X-rays, right? So the obstructing these electrons, and because of this obstruction, there is a shadow which is there. So here you have to understand that what are the most denser tissues. So first denser tissue is your implants. So whenever there is metallic implants, they cast the shadow very high. That is, they are white shadows, right? So because they obstruct a lot of the whatever the X-rays are there, they completely obstruct. They're impenetrable. Hence, they cast a whiter shadow, right? So they look whiter. They look bright on the X-ray. Then comes your bone, which looks again white. And then your cartilage. So coming to the cartilage, it is not that denser, so it appears dark, and followed by your water, which appears dark again, and then your air, the darkest. So based upon your tissues, this is how the X-rays are seen. So bone appears white. That is what is important for us. So because of that appearance of the white and brightest side on the X-rays form an important tool for us to understand what is happening inside the bone. So for example, you see this is the long bone. Now this is subjected to X-ray, and this is the X-ray. So this is A, the long bone which is subjected to X-ray, that is the X-ray shadow. So now you can see this X-ray on B. So similarly, if you see the exact structures here. So now let's read this or interpret this X-ray. So how do you interpret an X-ray? So interpretation of the X-ray is done in a following way, not to miss anything. So usually we remember it as A, B, C's of X-ray. So what is A? First, you always have to see the alignment of the X-ray. Then you have to see the adequacy of the X-ray, whether the X-ray is adequate, the exposure is adequate for the X-ray. To comment, right? So to comment the X-ray, you have to see whether it is accurately seen or not. So that is the A. And then you have to comment on the bone itself. So what do you see on the bone? The shape, the structure, the density of the bone, whether it is porotic, whether it is lytic, whether it is sclerotic. So you comment on the density of the bone, and you see the extra growths on the bone. So now you comment on the bone first. Then coming to the cartilage. So cartilage is usually not seen on the X-ray. Cartilage is just seen as a darker area over the X-ray, and these cartilage is nothing but your joints, right? So they are, whenever there is a darker zone between two ends of the bone, that is nothing but your joints. So after commenting on the bones, you have to comment on the joints, and finally you have to comment on your soft tissues which are present around the bone. So this is how you have to interpret. Now let's interpret this X-ray here. So first, let's see the alignment and accuracy is adequate. You can see whatever you want to see. And coming to the X-ray, so this area where you see the lighter version, so see here you can see nothing is there, so it is just dark, right? But it is present between your epi and meta. So you know by your knowledge that this is the growth plate, which is cartilage, and hence it is seen as a darker zone on the X-ray. So we have seen the bone. So coming to the bone, if you see the diaphysis, this is the highest density, so it is seen as the brightest one, right? And then you can see the metaphysis and then your epiphysis. So physis or the cartilage is seen as a darker part. So that is how you interpret the X-rays, right? And then coming to this X-ray. So as I've told you, you have seen the X-ray. So this is the, we have seen the adequacy is fine. Then we'll talk about the bone. So if you see the bone is brighter white in color, then you can comment about the density of the bone. So what is the density? Whether it is lytic, whether it is sclerotic, whether it is porotic. So what is porotic? So osteoporosis, then you see the cortex is not as thick as you see here. So the cortex here, it is very thick. So cortex is very thick, right? So in osteoporosis, you will see thinning of this cortices. So whenever the bone is appearing you weak or strengthless, you see osteoporotic, right? And what is lytic? Lytic is lucency. Sclerotic is dense. So again, lysis, lucency, it appears little dark, right, compared to your denser part. Here, sclerotic means it appears the whitest. So here, if you see the cortex here, the cortex in the diaphysis appearing in dense, and then your metaphysis, then epiphysis. Epiphysis is appearing somewhat dark and lighter version. So cartilage and your bone together there. So in diaphysis, it is the darkest one. So you can see in diaphysis, it's the denser. So it is the whitest in diaphysis. Okay. So that is about the bone. That is how you comment on the bone. If you see any lesion in the bone, then you can comment about its size. You can comment upon its size, the margins, and your periosteal reactions. So all this you can comment on the bone, right? So all this you can see on the X-ray. Now coming to cartilage. So in case of cartilage or joints, so first thing you have to see is the joint space. So this space is darker on X-ray, but this is occupied by the cartilage, right? Whenever there is a cartilage erosion, whenever there is a cartilage damage, there will be decrease in the joint spaces. So there will be decrease in the joint space because of cartilage damage, and sometimes there might be increase in the joint space because of effusions. So you can see increase or decrease of the joint space, and then you can comment on your subchondral cysts which are present down this joint margins. So subchondral cyst, then you can see erosions of the joints, or you can ultimately comment upon your loose bodies in the joint. So these are the osteophytes which are forming in case of your degenerative arthritis, and these osteophytes sometimes they get separated from the bone and they present as loose bodies. So you can comment on the loose bodies, or you can see the joint erosions, or you can see the margins which are eroded, right? So you can comment on the various changes of the joints, and ultimately the soft tissue. In case of soft tissue, you can see the disturbances in the planes. So a disturbance in soft tissue planes. Sometimes you can see the calcifications, right? Calcifications or ossification in case of soft tissue planes. Okay, so this is how you comment on the X-ray. So first you start with the adequacy, then you comment on the bone, then on the joint space, and then on the soft tissue, right? So basing on this decreased in joint space and subchondral cyst, you can tell there is an arthritis. If there is a periarticular erosion around it, then you can comment it as an inflammatory arthritis. If there is just bone destruction with your periosteal reaction, then you can tell it as an infection. So based upon the X-rays, you can come to a diagnosis. So that is how X-rays are very much useful. But adding to so much advantages of X-rays, what are the disadvantages? So disadvantages are, these are ionizing radiation, right? These are nothing but the ionizing radiation. So that means they can result in radiation-induced cancers. So there is radiation-induced cancers on this radiation. That's why you have to be very careful for the exposure of the radiation. And then there is certainly damage to the fetus, especially in the first trimester. So pregnant women should be warned for this X-rays during the first trimester, right? So these are various disadvantages of X-rays. And coming to rules, so there are certain rules in X-rays that you have to remember. So first rule is fracture should be in center of the X-ray. So this is mainly for trauma. So these rules are mainly for trauma. So fracture should always be, whenever you're suspecting a fracture in a particular patient. So for example, if it is a humerus fracture, shaft fracture, then that you have to see that part is in the center. So that means there should be two joints covered. So one joint above and one joint below should be considered for the X-ray. And the third point is two views. Always go for two views. So there is an AP view and there is a lateral view for the X-ray. So in AP view, what will you see? So coming back to this X-ray, this is two views of the X-ray of ankle. So this is the AP view of ankle and this is the lateral view of the ankle. So why do I need two views of an X-ray? For example, let me take this particular gadget, right? So if you see, if I ask you to tell me the name of this particular gadget here, and if I show you like this, can you read the name? You can't read the name, right? If I show you like this, you can't read the name. Only if you can see the anterior portion. So let us assume that this is the anterior surface and this is the posterior surface and this is your side or the lateral surfaces. So if I ask you what is written, what is the name or brand of this gadget, you need a view which is called the AP view, right? If I put AP view in front of you only, you can tell that there is some name on this gadget that can be read. And if I say what are the various portals present on this side, so for that you have to turn it and then see. So like this, you can't comment upon the portals which are present here. So you have to turn it this side. So for commenting on the bone, so to comment to the bone, what is the type of the fracture? You need two views. So you can't judge only on one view, and getting one view of the X-ray is as waste as getting no X-ray, right? So whenever you order an X-ray, always see that there are two views ordered. So for example, in certain areas where you have to go for three views also, special views are to be added for diagnosis of that particular fracture. So with these views, you get some orientation of the fracture. So for example, in ankle, if I want you to comment on posterior malleoli, this posterior malleoli is only seen on your lateral X-ray, because on AP X-ray, you can't comment on the posterior malleoli. You can only see the medial malleolus and the lateral malleolus. So AP view is for your medial and the lateral surfaces. So lateral view, you confirm the anterior and the posterior surfaces. So here on the lateral view, you can see what is anterior and what is posterior. So on the posterior aspect, you can comment on the posterior malleolus. That is why you have to always order for two views, right? So that is the importance of two views. And then the importance of two joints, you already, in case of trauma, you know, there are always the fracture dislocations which are common. For example, your Montigia, if there is a forearm fracture, there could be a dislocation, that is proximal radioulnar dislocation. So that is why you have to always go for a one joint above and one joint below. And then always compare. So compare two sides compared with right and left side. And this is very much important in case of your pediatric practice, right? In case of pediatric population, you have to always go for comparison with the normal one. Then only you can comment on the abnormal one. So after having understood that, I've told you some special views. So let us see what are the special views, right? So the first special view, right from the shoulder. So there is a special view for shoulder. Rather than AP and lateral, you go for your axillary views. Axillary views where you take view from the axilla. Here you can see your coracoid process, which is very much neatly seen on the X-ray. And you can see the anterior and the posterior of your glenoid joint. So glenoid and humeral head, the anterior aspects and the posterior aspects with your coracoid and your acromion can be easily seen on your axillary view of shoulder. Then coming to your wrist. You have your very important carpal bone, that is scaphoid. So to identify the scaphoid fracture, you have to go for this oblique view, right? And then your acetabulum. So coming to acetabulum, you have this very important Judet views. So Judet view is seen in acetabulum, where you can comment on the fracture of acetabulum. Like acetabulum fractures are anterior column, anterior wall, posterior wall fracture. So to comment on this particular columns and walls fracture, you go for this Judet views, right? And then coming to your knee joint, to see your patellofemoral joint, you go for a view which is called as your skyline view. So here you flex the knee and take X-ray from the upward. So here you get the patella and the femur. The patellofemoral joint can be commented based upon this skyline view, right? And then coming to the ankle, Already we have discussed ankle. So AP lateral is important. And one more important view here is your mortise view. This is all because of the overlaps of the bone. So to correct this overlapping, you go for the special views, right? For example, in the ankle, to comment on the joint surfaces, to comment on the talotibial joint surfaces clearly, you go for this mortise view. What is a mortise view? It is 15 degrees internal rotation of the ankle that will result in the mortise view, right? So that is the special view for ankle. And then there is subtalar joint. Subtalar joint, if you want to comment on the subtalar joint, you have to go for Broaden's view. So Broaden's view is for your subtalar joint. And then finally, there is calcaneum. So to comment upon calcaneum, you have to go for your axial view. So you go for lateral view of heel to comment the calcaneum and also the axial view to comment the calcaneal tuberosity. Right? And remember, for ordering x-rays for your wrist, so ordering x-rays for your hand and your foot, you go for your AP and oblique instead of your AP and lateral. This is mainly for your metacarpals and your metatarsals to overcome the overlap, right? So these metatarsals and metacarpals are arranged in such a way where if they take an AP and lateral, you can see nothing. So in the lateral view, you can't comment on the fracture side. So because they are arranged in such a way, for that you go for AP and oblique view for your hand, for commenting for the metacarpals, and your foot for metatarsals. So this is about the x-rays, and I hope you put this in a tabular form, the various views, so that you can revise just before your exam. So that is about your x-rays. So coming to the disadvantages, we have already discussed that it is the ionizing radiation, which is very carcinogenic, and your fetus. With that, I add one more thing. What is that? Is your soft tissue. Soft tissue contrast cannot be seen. So you can't comment much on the soft tissue, right? You can't comment on the tendons, you can't comment on the ligaments. So this is soft tissue cannot be commented based upon your x-ray. Now we'll go to one more modality, that is your CT scan. So why have this CT scan had been invented? So what is a CT scan? CT scan is nothing but your computed tomography. So what does tomo mean? Tomo means that is depth, and here you get the 3D version of your bone or your joint. Right? And how does the CT scan occur? So they place you are put in a supine position over the gallantry, and then there is a rotating X-ray machine. So there is a rotating X-ray machine which is present around you, and they are taken in case of sections, right? So here you can select a particular part. So for example, if you want the X-ray of the knee, you can select the knee joint, particular part, and then you can take the sections of the knee joint. So this is one of the latest thing. The transsectional images can be taken, transaxial images can be taken from the CT scan, and you can add a 3D version to the CT scan. So you can see the joint or the bone in a 3D dimensions. So why is this necessary for us? So mainly the CT scan is necessary for fracture planning. So planning of the fracture fixation, right? So you need the orientation of the fragments. So how are they oriented? How can you bring them together and fix it? So for that orientation, for pre-planning of your management, you need the CT scan. Especially these are important in your periarticular fractures. So in case of your periarticular fractures, they play an important role, right? So they play an important role in periarticular fractures. And whenever you want to comment on the bone, always go for CT scan. So here, because this is also a type of radiation, ionizing radiation, a type of X-ray, where you can see bone even more clear. So you can see the bone with greater resolution, right? So bone you can see with the greater resolution, and with more orientation. So that is why whenever you want to go for the bone, comment on the bone, which are not visible on the X-rays, then you go for a CT scan. So this is the CT scan of the same ankle. So if you can see, this is the X-ray of the ankle. So this was the X-ray of the ankle, where you can see the bones talus and calcaneum. But when you come to the CT scan, you can see it's even more clear. So this is your CT scan. So here you can see, you can define the margins even more clear. The joints are clearly seen here. So this is the joint orientation, which are very clearly seen. And if there are any fractures which are present, they are more clearly visible. So that is why you go for a CT scan. So whenever you want anything related to bone or a joint or fracture management, you go for a CT scan, right? So that is how CT scan is useful for us. So similarly, what are the disadvantages of CT scan? Disadvantages is, again, it is ionizing radiation, so there is exposure increased, right? And again, there is again a problem with the soft tissue. You can't see the soft tissue or comment on the soft tissue again on the CT scan. So soft tissue interpretation is not possible, right? So here there is an X-ray. So similarly, if you can see, this is the calcaneum X-ray, right? So this is a calcaneum X-ray, and barely you can see a fracture or whatever is seen on this X-ray. So you can see a faint line here, and with your clinical knowledge, you know there is some tenderness to the patient or some swelling to the patient, and based upon the history, you're thinking it to be a fracture. So to confirm your diagnosis, the next step of management is your CT scan. So in the CT scan, if you can see, you can clearly see this fracture pattern. So here there is a fracture, it is even extending into your subtalar joint. So this is a fracture. So similarly in other visuals, so these are the sections which you can take, and this is the fracture pattern. So this is the fracture pattern. So this is how your CT scan helps in your fracture management, right? So that is about the CT scan. Next, coming to the MRI. So in X-ray and MRI, we were so very disappointed that we cannot comment on the soft tissue, and we were even not happy with the ionizing radiation because they induce cancers. So both these problems are dealt with your MRI. So MRI is not using ionizing radiation, hence it is safe. And then it is a very good tool, and excellent soft tissue interpretation is possible with your MRI. So whenever you want to comment on your soft tissues, such as your ligaments, tendons, right? Such as your ligaments, tendons, your menisci. So all this requires your MRI, and MRI is very much useful mainly in case of your sports medicine and your spine. And it is safe in pregnancy. So it can be used in pregnant women, right? But there is also clause for your MRI. It cannot be used in patients who are already having implants, right? So metallic implants, and especially in patients with the pacemakers. So these two are the persons where your MRI is contraindicated. So MRI contraindicated in case of your presence of your pacemakers, and then your people with the implants, right? People with implants in their ear or brain, so they are not supposed to be subjected to MRI. So what is this MRI? MRI is nothing but your magnetic resonance imaging. Magnetic resonance imaging. So what does it do? So here it takes the principle of magnetic field, and there are cells in the body. They has protons. So when you are placed in the external magnetic field, when a particular person is placed in external magnetic field, these protons get excited and they start spinning. So this spinning is subjected to various frequencies, various radio frequencies and various modalities, and by which they get aligned, and then they produce images which are called as TW, T1, T2 images, right? T1 image and T2 images on X-ray. There are other type of images which are called as proton density images and fat suppression images. So let us see what is T1 weighted and T2 weighted images. Right, so there are T1 and T2 weighted images. So there is a lot of physics happening here. So that is mainly based upon your protons which are present in your body. They get aligned because of you're subjected to the strong external magnetic field, right? And what is the T1 weighted and the T2 weighted image? So let's see here. So this is water white on 2. So remember WW2. So whenever you see water or fluids white in color, then they are T2 images, right? And the other one is your T1 image. So why this T1 and T2? So remember 1 and 2. So 1, what are the subjects you deal in your first year of MBBS? Anat, physio and bio. So first is for your anatomy. So in T1 weighted image, you can see your anatomical structures clearly. So you can read the anatomy very clearly on your T1 weighted image. So for your anatomy, go for T1 weighted image. For your pathology, so what are the subjects you go for your second year? Path, micro, right? So pathology is second. So T2 weighted images, you go for your pathology, right? So you want to comment on the pathology, go for your T2 weighted. You want to comment on anatomy, go for T1 weighted images. So that is T1 weighted and T2 weighted. And then what is proton density and fat suppression? Proton density is nothing but combination of T1 and T2, and it is mainly important for orthopedics, where you can read about your tendons and ligaments. And fat suppression is also important in orthopedics because this fat is suppressed, where you can comment on the marrow edema, right? So if you see in the marrow, the bone marrow is full of fat, right? If there is fat and there is water, the signals are almost same from fat and water. So now there is a recent technology where you suppress the fat completely. So signals from the fat are suppressed completely. So these water signals are taken up and you can comment on the marrow edema. So bone marrow edema can be commented by this fat suppression. So there are various ways where they suppress the fat, and one such example is your stir image. So stir image is taken out for this fat suppression to comment upon your bone marrow edema, right? So that is how MRI is taken out, and MRI is important for us. So what are our specialities where MRI is playing an important role? As I've already mentioned, your sports injuries. So in this particular knee MRI, if you see, there is a ligament damage. So this is the meniscus, sorry. So this is the menisci. So this is the menisci. And here is one more meniscus. So meniscus is usually seen as a triangular structure like this. So this is the meniscus. And similarly, the opposite lateral meniscus, which is seen like this. And whenever there are tears, you can see as the white structures lying like this. If tears are present, you can see some disruption in your structure, right? Usually it is completely black in color. But if there is some tear, you can see there is a white interruption in the black. So that is your meniscal tear. So by this, you can identify the meniscal tear. So it is very, very important in case of sports medicine, where you can comment on your ligaments, you can comment on the tendons, right? And meniscus. And it is also important in your spine, where you can see the disc prolapse, your stenosis, lumbar canal stenosis, and in case of infections, for your planes, wherever the soft tissue planes are disturbed, you go for an MRI. right? And ultimately, it is also important for your avascular necrosis. So diagnosis of the avascular necrosis, where the blood supply is decreased for the bone. So this could again be identified on the MRI, right? So this is the avascular necrosis where MRI is important. So these are certain areas where your MRI plays an important role for the diagnosis, right? And this is the picture of the MRI showing your avascular necrosis. So if you can see, this is your AVN of what bone? This is the talus. So this is the avascular necrosis of the talus bone, where you can see the patchy signal intensity. So there are some gray color variation in the MRI, right? See here you can see this is white color, so this is dark. So here the bone has become dead, so this shows as dark color. So this is the avascular necrosis of the talus on the MRI. So these are the various areas where MRI is useful, right? And if you still want to comment on various structures, you can go for contrast MRI, such as your spine, where you use gadolinium compounds for your contrast. So these are the IV injected compound into the body, and then you read the MRI again with this contrast. These are useful for various areas where you can't judge the soft tissue diagnosis. You use this gadolinium compounds for contrast MRI, right? And now then coming to ultrasound imaging. So once we are done with MRI, now there is ultrasound, which is also one of the tools used in orthopedics. And this ultrasound uses the concept of sound waves, right? So they use the concept of sound waves where the transducer is present. So this is the transducer, and this transducer will send us certain signals, and based upon the receiving echoes again by your transducer, there is an image which is formed. So here they depend upon the interfaces. So they depend upon the water interface or air interface, the signals are collected. So where are these used for us? They are used for diagnosing the cyst, and mainly they are used for tendons, right? So one such area is your Achilles tendon. So that is the strongest tendon in the body, Achilles tendon. So this tendon rupture or partial tears of your tendons can be detected on the MRI. Similarly, your rotator cuff tears can be detected on the ultrasound, right? So there is a cyst. So if this cyst is fluid filled, this can be picked up by the ultrasound. So ultrasound is the tool where we use for detecting the cyst, and then you can go for your tendon diagnosis, such as your tears, your partial tears, your ruptures, and rotator cuff tears. And one important area where this is very much useful is your screening for DDH, that is developmental dysplasia of hip in children. Right? So this is the area where ultrasound plays an important role in our department, that is your DDH. So this is the image of your femoral head. If you can see, there is FH, that is femoral head, right? And this is the ilium part, and this is the triradiate cartilage. So based upon the angles, so based upon the femoral head orientation, we take out the angles, alpha, beta angles, and based on that, they tell us what is the stage of DDH. So developmental dysplasia of hip is one area where your ultrasound tool plays an important role, right? So that is about the ultrasound in case of orthopedics, right? Then there is one more called your radionuclide scanning or your bone scan, or your bone scintigraphy. So what is this? So this is an area where we use radionuclide. This is taken up by the tissues, and this radionuclide will emit photons, right? They emit photons, and these are captured by your gamma camera. Right? Gamma camera. And based on this, you will tell whether the bone, what is the various pathology happening in the bone, right? So for this radionuclide, the radiopharmaceutical agent which we are using is your 99M technetium. Technetium 99M is the ideal radioisotope which is used for your radionuclide scanning or bone scan. So this is taken up by the tissues, and then they emit certain photons which are captured by your gamma camera. So this has two ingredients. So one is chemical which is taking up, and then you have your tracer, right, that will emit the photons. Right, so these are two important ingredients which are present in this technetium, and this technetium is injected IV, and then there are two phases which you subject the patient to. One is called the perfusion phase, and the second one is called your delayed phase. So perfusion phase is where there is an increased vascularity. You can see there is increased uptake of this particular product. So you say there is a hypervascular area where there is an increase in perfusion phase. If what is delayed phase? This is 3 hours after infusion. That is the delayed phase, and this is the bone phase. So whenever there is an increased uptake of this particular product in the bone phase, you say that bone has become vascular, and there is an increased area where there is an increased bone formation. So the bone uptake is more. If it is not taking up as normal, then there's a decreased bone. That means it is a dead bone, right? So that is how you diagnose the conditions. So there is one more compound which is called 99 technetium M, that is hydroxymethylene dihydrophosphonate. So technetium 99M HDP, hydroxymethylene dihydrophosphonate. This is also being used, and this is after injecting this IV, they go into 2 phases, that is perfusion phase and the delayed phase. So based upon that, you decide what type of pathology is happening in the bone. For example, this is the calcaneum, and there is an increased uptake in the bone. So that means there is a fracture. So where there is an increased bone formation, there will be an increased uptake. So when there is increased bone formation means based upon the history, based upon the x-rays, we want to comment whether there is a fracture. So because we have confirmed it by bone scanning, there is an increased uptake. That means there is a fracture in the calcaneum. So that is how you can diagnose based upon the bone scan. So what are the various areas where these bone scans are used? So first, you always use this for multiple lesions, such as your metastasis, multiple metastasis, right? And then you can detect infections. So increase uptake, increase the vascularity will tell you that there is infection happening in the body. So in case of infections, so you can take them even in case of stress fracture, where there is an increased uptake. So whenever there is a fracture, there is an increased bone formation, right? So then the radiotracer is taken more. So that is a stress fracture where you can use. So even for implant loosenings, so whenever there is an implant loosening, you can use this bone scan for detecting the implant loosening. So you can tell whether there is infection happening in the implant loosening or what is the condition of that implant. So these are the various areas where the bone scan is used. Especially it is used for your metastasis, where more than one area you can detect, because here the entire body is scanned at once, right? So multiple lesions can be detected easily. So that is the area where bone scan or nucleoid scanning is used. Right, that is about the bone scanning. But the disadvantage of bone scanning is it is very high radiation. Very high radiation. So usually with the non-invasive technique like MRI, and MRI is one such very non-invasive technique, right? So because usage of MRI is more, bone scan usage is limited. But you can use this bone scan whenever you have a doubt for multiple structures. And there are two important compounds which you have to remember. That is gallium-67. This is taken up by your inflammatory cells. And hence it can be used in infections. And there is indium-111 labeled leukocytes. This is one more type of bone scanning which you can take for detecting the infection. So these are also, especially the WBC are taken out and they are labeled with indium and they are injected into the body. So this is mainly for usage of your infection. So the gallium-67 or indium-111 labeled leukocytes, right? So that is about your bone scan. And now coming to your PET scan. So what is this PET scan? PET scan is positron emission tomography, right? PET scan is positron emission tomography, and here the isotope which is used is fluorodeoxyglucose. So 18-fluoro-2-deoxy-D-glucose. So this is the radio tracer, which is a radioisotope which is given to the patient. And here this is mainly useful for detection of malignancy, and these cells mainly use glucose, right? So they take up this PET scan. And whenever you see there is an increased uptake of this glucose of this radio tracer, identify the PET scan, then you can detect the metastasis. You can detect the secondary. So that is the importance of the PET scan. Now coming to one more important scan for identifying your bone mineral density, that is your DEXA scan. So bone mineral density. So shortly it is called as your BMD. So bone mineral density you have to identify mainly in case of your osteoporosis. So if you want to see somebody suffering from osteoporosis, you have to go for this BMD test. So what is this test? So this test uses your low dose X-rays. Low dose X-rays are subjected to particular areas such as your hips, your vertebrae, and then your calcaneum. So these low dose X-rays are subjected to your hip, vertebrae, and calcaneum specific sites. And now there are two energy levels which are used to compare the density of bone comparing to a soft tissues, right? So the density of bone is calculated compared to a soft tissues. Then you get scores. And these scores are in form of T and Z scores. So what is this T and Z scores? So after calculating the scores, when you compare your scoring with a peak bone mass. So when you see this peak bone mass in your 30 years of age. So when you subject your score to a 30 years old man density score, then it is called your T-scoring. When you subject your score to same age and the same sex population, then what you get is your Z scores, right? So I hope it is clear. So T-score is where you go for peak bone mass, that is 30 years. Z score is same age and same sex density. So you compare the density of you to your peak bone mass. That is, if at all, if a patient of 50 years, T-scoring, then you compare it to 30 years bone density. So if 30 years, what is the bone density? To this particular patient of 50 years, what is the bone density? So what is the standard deviation of that particular patient? And Z score is 50 years of that patient. Z score is 50 years of same population. Right? So a person of 50 years, how much density of bone is there? And what is the patient of 50 years having the same density? So that is standard deviations of these two people are compared. Right? So now these are given in terms of standard deviations. Right? If a standard deviation, if it is one standard deviation less, it is normal. If it is somewhere less than 1 to 2 standard deviations, it is osteopenia. And then if it is less than 2.5 standard deviations, then it is osteoporosis. So that is how you have to calculate your DEXA scan based upon the standard deviations. So T is comparing to the peak bone mass, Z is comparing to same age and same sex population. So this is about your Z scoring. Whenever it is less than 2.5, you diagnose that patient as osteoporosis patient, right? So that is about your DEXA scan. And usually this is advised 60 years females of age 60 years and 75 years males. So all patients with this particular parameters have to undergo this DEXA scan, or if the patient is 50 years with any sufficiency fracture, such as your hip sufficiency fracture, your distal radius fracture, or your vertebral fracture, then you have to go for DEXA scanning at the age of 50 years. So that is the machine which is in carrying out the national osteoporotic screening. So there you have to undergo this DEXA scan to diagnose your osteoporosis. Now, next topic is about your synovial fluid analysis. So what is a synovial fluid? So synovial fluid is nothing but the fluid which is present in your synovial joints, right? Synovial joints. From where is this fluid coming into the joints? So this is nothing but your ultrafiltrate of plasma. So ultrafiltrate of plasma, and then this is secreted into the joint by your synovium. Into the synovium. So secreted by the synovium into the joint is the synovial fluid, and now this combines with the hyaluronate. Hyaluronate is nothing but again secreted by synovium, your hyaluronic acid, and these together will form your synovial fluid. So this synovial fluid is important for lubrication of the joint, and it also has few WBC cells which acts as defense, right? And because of your hyaluronate which is present, it is highly viscous. This is highly viscous, right? So this is about your synovial fluid, and on appearance it is clear and colorless fluid. So this is a clear and colorless fluid which is highly viscous, which because of the presence of hyaluronic acid, and it is secreted by the synovium, and it is nothing but your ultrafiltrate of plasma. So your plasma gets filtrated, so your high molecular weight proteins are left out, and then this is secreted into the joints. So when I say that, that means the protein level is also same, slightly different because of high molecular weight protein are lost, and then your glucose and your uric acid levels are also same with the plasma, right? Same with the plasma. So that is about your synovial fluid. Now this synovial fluid, if you see, this is the normal synovial fluid, this is clear and colorless, and this is your bloody synovial fluid. It might be seen in case of traumatic events where your blood is collected in the knee joints, and once you aspirate it is bloody. Right? So so that means your synovial fluid has to be aspirated for your analysis. So how do you aspirate your synovial fluid? So for that you have to maintain a strict aseptic conditions. So on these strict aseptic conditions, you introduce the needle into the knee joint. Mainly your 20 gauge needle is introduced, and then your fluid is withdrawn. Fluid is withdrawn. And on drawing of the fluid, if you see it is bloody, that means it is traumatic. If you see it is cloudy, it means it could be any crystal-induced disease, and if it is turbid, you can tell it is inflammatory, right? So these are, if it's purulent, you can tell it is pyogenic. So based upon the appearance itself, you can come to a conclusion of the diagnosis. But normally it is clear and colorless, right? So this is the aspiration. So now you do with a needle. So you put a 20 gauge needle into the knee joint, and then you withdraw the fluid, and you send this fluid for analysis, right? So before doing that analysis, there are two important tests which you have to do. One is your patella tapping test, right? And the second one is your fluctuation test. So patella tapping is nothing but whenever the knee is effused completely, you tap onto the patella, and because of the fluid which is present under the patella, this patella keep bouncing back. So this is your patella tap positive. So whenever that is positive, that means there is a knee effusion which has to be dealt. And then your fluctuation is similarly like your fluctuation test in any other cyst conformation. So once you press the cyst on the opposite side, or the knee joint effusion is squeezed on the opposite side, the one side or the opposite side gets enlarged. So the fluid gets accumulated there and it gets enlarged, right? So that is your fluctuation test. So when these two tests are positive, you go for knee aspiration, and on aspiration you analyze the fluid. So there are various parameters. So first you see the appearance, and based upon the appearance, and then you send for the synovial fluid analysis. So this is what you send for the analysis, and you can diagnose certain joint disorders based upon your synovial fluid analysis. So first, as I've already told you, it could be trauma. The second one, it could be infections in case of septic arthritis, and third, it could be inflammation, right? And you can diagnose the crystal joint disorders, right? And then in case of crystal, you have your gout and your pseudo gout. So gout is nothing but your accumulation of uric acid crystals, and in case of pseudo gout, it is nothing but your calcium pyrophosphate deposition. So CPPD, right? And in case of joint infection, so whenever there is joint infections, again you can go for your synovial fluid analysis, where there will be increased WBC count in your fluid, right? And you can also diagnose between your osteoarthritis and your inflammatory arthritis with your synovial fluid analysis. So now let us compare the various parameters between all these joint disorders. So first, let me write all the normal values, and then we'll see what is abnormal in each disorder. So normal, I told you, that is colorless and it is highly viscous. So normal, it is colorless and clear, and it is highly viscous. And WBC, I told you, it is almost less than 150, and there are no crystals, no abnormal biochemistry, and there is no bacteria, right? And when it comes to non-inflammatory, that means your osteoarthritis. In case of your osteoarthritis, so what will it be? It could be somewhere around yellow, or it could be clear again. and viscosity is still high, and this white cells is still 150. There is no crystals. Sometimes there could be some crystals, but there is no importance in biochemistry, and there are no bacteria. So here your osteoarthritis can be diagnosed. Still it is clear, still it is normal looking, right? Only the amount of the fluid is very, very minimum, and this, because of the loss of this hyaluronic acid also, you can get this osteoarthritis, right? Then coming to inflammatory arthritis. When I say inflammatory arthritis, so there is some amount of inflammation which is happening here. So what is inflammation? So you have to recollect your inflammation from pathology, like there will be increased permeability, there could be fluid accumulation, there could be infiltration of various cells. So when I say cells, those are your WBCs. So it could be increase in the cells. There could be from 200 to 2000 of the cells which can see there in inflammation. So first thing is there is increase in cells because of inflammation. So whenever there is increase in the cells, the whatever the fluid which is clear will not look clear because there is some amount of cells which is present. So this might look turbid. Turbid is something, depositions are there in it. So some depositions are there in it. So the viscosity is low. So because of the increased cells and because of your hyaluronic absence, there is the decrease in the viscosity, but there are no crystals and biochemistry is still absent, and there is no bacteria. So this is your inflammatory, where your cells will be increased, right, in case of your inflammatory. And coming to septic, this is very important. Whenever I say septic, that means there is an infection which is happening there. So infection is nothing but high amounts of WBC. High amounts of WBC, right? And whenever there is an infection which is high, you can see sometimes purulent, and viscosity is low because of very high cells, and the crystals are not there, but there are presence of bacterial cultures. And when coming to biochemistry, your glucose is low, which is eaten away by your bacteria. So low glucose when compared to your plasma. Here in case of biochemistry, let me write that the glucose and the uric acid is as normal to plasma. Right? So here when it comes to septic, when it comes to infections, your glucose is decreased, very low. And similarly, your tuberculosis. Tuberculosis also, there will be turbid, and there is low because again there will be cells which are inflammatory cells are increased. Here this inflammation is lymphocytes, here it is neutrophils. So when I say pyogenic, it is in neutrophils, and whenever I say tuberculosis, that is lymphocytes, right? Again there are no crystals, and again the glucose levels are low, and this could be positive for your bacteria, that is Mycobacterium tuberculosis. Culture is usually very late, we don't do cultures here. Gram staining we do for your bacteria, that is Mycobacterium tuberculosis. When it is crystal induced, so in case of gout or pseudo gout, straight away you get your uric acid crystals, that is monosodium urate crystals are positive, right? And in case of your pseudo gout, CPPD crystals are positive. So this is also a type of inflammatory. So again, there will be increase in cells. So again, it will look turbid, right? Again, the viscosity is low. Crystals are positive here. Bacteria is negative. And coming to trauma, this is bloody, low viscous, increase in cells, right? There are no crystals, and sometimes this could be normal with the glucose and all, and there is no bacteria. Right? So this is how you come to a diagnosis for your synovial fluid analysis. So whenever you see just a bloody discoloration, which is red in color with lot of RBCs in synovial fluid, then you conclude this as traumatic effusion. This is hemarthrosis. This is hemarthrosis. Hemarthrosis, right? So fluid volume also will be high in case of hemarthrosis. In case of septic, this is purulent with high amount of cells, that is WBCs, and there is decreased glucose, right? And your bacteria cultures are positive in case of your synovial fluid analysis. So this is how you come to a conclusion of various disorders of joints using your synovial fluid analysis. This synovial fluid analysis can be done even with the 0.5 ml of fluid which is available, and this is one of the very easiest method of coming to the conclusion. But it is also the most neglected one. Also, usually we go for imaging for coming to the diagnosis, but this can also be a tool mainly for your crystal-induced disorders, where you can see monosodium crystals and your calcium pyrophosphate crystals in case of gout and pseudo gout, right? So that is about your synovial fluid analysis. Now coming to the last tool which is present and the ultimate tool for your final diagnosis of mainly your tumors and infections is nothing but your biopsy. So this is your tissue diagnosis which is there. So tissue is taken here. This is the tissue diagnosis, right? And coming to the biopsy, there are two types of biopsies. One is excisional biopsy. So you take the entire part, you excise the entire part and send it for biopsy. And then there is incisional biopsy. Incisional biopsy is what we mainly take in orthopedics. So this is important for us. And again, incisional you can take with the help of open or closed biopsy. Open or closed. Open is not usually encouraged. We go for closed biopsy. Why closed biopsy? Because in case of open, you have to subject if it is a tumorous condition, you have to subject to the entire tissue which we are opening from, right from the skin to the lesion. You have to expose the entire surroundings, right? So we use this closed type with help of needle or a trephine. We use the needle or the trephine to enter into that lesion, and then we take the biopsy. So this can be done with the guidance of imaging, that is your CT guided or ultrasound guided, or it can be done using your C-arm guided. So we take the help of the imaging and we go to that lesion, and when we take a small piece of the tissue, and this tissue has to be sent for your histopathological examination. So when you have a doubt whether this is a tumor or infection, then you have to send it for culture, and then you have to send it for histopathological examination. So this is where you ultimately come to a final diagnosis, and this is the gold standard diagnosis in case of tumor or infection, right? So this is the biopsy, and there are certain important things you have to follow for biopsy, because in case of tumors mainly, the biopsy should be the last option. So first you have to complete all the radiological tools which are available, all the diagnostic modalities which are available, then you have to go for your biopsy in case of tumors. And this biopsy should be done under anesthesia in the OT, and it should be done by the apex surgeon who is ultimately going to deal with the tumor. So that is the important, and the surgeon who is doing should be aware of all the incisions and all the approaches, so to not to contaminate the other compartments if it is tumorous condition, right? So this biopsy should be preserved and it should be sent for HPE, and before that you have to keep in touch with the pathologist so you can discuss the condition in detail, because you can't repeat the procedure of biopsy again and again. So you have to take ultimate care before doing biopsy, and you have to meet all your important colleagues such as your pathologist, your microbiologist, and inform them this is particular condition which is prevailing in the patient and we are going for this particular type of biopsy. So that would help the pathologist or the microbiologist to come to the conclusion, and ultimately you can arrive at your final diagnosis for any patient, which could be the end for your all the type of examinations, right? So this final diagnosis is what is important for proper management and proper recovery of the patient. So that is about the diagnostic tools which we have in orthopedics, and that ends your topic of very first introductory topic and your topic on diagnosis in orthopedics. So hope you all understood, and hope you all have a good idea about all these tools, when and where to use your each and every tool. Okay, so that completes the topic, and thank you for your patient listening. See you in your next video.